All right, good morning everyone, the Spine Conference. Just a reminder, I record this and post it on YouTube. And today's lecture will be on spondylolisthesis. And we'll start with an illustrative case. This screen shows Millennium Force, which I'm going in 3.5 weeks, our annual trip to Sandusky, Ohio. My children demand it.
To what?
Sandusky, Ohio, Cedar Point, biggest roller coaster park in the world. And this roller coaster is 315 feet tall. Millennium Force. It's one of the few that I don't feel like throwing up. I feel slightly like throwing up afterwards, which is good.
Going down doesn't seem like you're going down at right angles.
It's very close. It's like 87 degrees. I'll show you another one that's more than 90. Okay, so this is the first case. It's an illustrative case. It's a case, Aaron, that we just did on Tuesday. 57-year-old man, and he has low back pain. He works as a refinery operator. So that's not him, but it might as well be because he described this job. He says it's physical. It's a lot of heavy, like turning knobs and pieces of metal and climbing ladders hundreds of feet into the air in a big refinery. So it's a physical job and requires some level of agility too. It's in Delaware. I forget the name of it. So his chief complaint is low back pain. It's worse when he walks. It's in his lower back lumbar area, posteriorly in the midline at the belt, goes to his left hip and also right lateral thigh. He is is a healthy man in general. He's had a left ACL reconstruction and a knee scope. He's a cigarette smoker, and he's 5'10", 230 pounds. So.
He's obese.
Well,
Technically he's obese.
Yeah.
Yeah.
By body mass index, but he's a very large man. He's muscular. So.
Heavy bones.
Well, he does have heavy bones, but he's got. How would you describe him, Aaron? He's kind of like a linebacker type body.
Mesomorph.
He's a mesomorph, yeah. So I mean, 230 pounds can vary in what it's made out of. I mean, it's not important, but it is important in the sense that it makes the surgery difficult because these muscular men, like linebacker or offensive lineman type men, have very thick back musculature, and it makes the surgery difficult because you have to get to the spine. Mm-hmm. So, Aaron, what do you see here on the X-rays? AP and lateral view of his lumbar spine. So his low back pain. So the first thing we do, just another thing on exam. His exam is non-focal. He's a normal man, normal motor sensory.
AP has a slight curvature, but on
slight curvature at L2, L3. Mm-hmm.
On the lateral view, there's a spondylolisthesis L4, L5.
Mm-hmm.
Maybe close to a grade 2.
Yeah. So it's a grade 2, I would say.
Decreased disc height. Let's see.
At L2, L3.
2, 3.
Mm-hmm.
And 4, 5.
And decreased disc at 4, 5. Great. So that's basically it. So normally the spine has a normal alignment. All the posterior vertebral bodies totally line up, and you can see there's an obvious shifting of this abnormally of the spine focally at L4, L5. So those are standing X-rays. What about the flexion view, Aaron? Is that normal?
Maybe slightly worsened.
Yeah, so I think it's slightly worsened at L4 or 5 when he flexes forwards. And these are the oblique views. I just added them to be complete. I don't think they really add much. They don't really add much to the diagnosis and care of this man. So just to give a couple terms, so spondylos is the Greek word for vertebra, and listhesis just means slip, something slipping. Spondylosis, which is a term that we use all the time, it just means something's abnormal in the spine, something's degenerative in the spine. It's a catch-all term for everything. Now, lysis means a separation. So spondylolisthesis is basically a separation of the vertebral body between the front and the back of the spine, and it's usually at the isthmus, which is pointed out there in the arrows. I'll tell you what isthmus is. Optosis means falling off. Discitis just means an inflamed disc. And pars interarticularis is the area between the two joints. And you can see those two arrows. That's the area between the facet above and below. So that's where all these words come from. They're very confusing for someone who doesn't do spine, like as a medical student or a regular doctor.
So that the word spondylos expanded a little bit, changes its meaning.
Spondylus,
and
spines,
spondylolisthesis.
spondylus spine, like vertebra.
Yeah. Then
Yeah.
you put an IS on the end and it becomes a genitive, the meaning of the word.
Spondylosis, yeah.
Spondylosis.
It basically something's wrong with the spine.
Yeah.
That's all it means. And it's a radiologist use the term the most. They just say, usually surgeons, we just use the diagnosis low back pain. It's like for us, it's more descriptive. But radiologists usually use the word spondylosis. So when you have a fracture of the pars interarticularis, this is a case of a fracture of the pars interarticularis. On the left is a CT scan, on the right is the MRI. And the CT scan, the CAT scan, shows cortical bone much, much better than MRI does. You can see on the MRI on the right, the cortical bone is black. In fact, you can't really see it. But on the CAT scan, it's very clear. It's a clear, defined white border. And also, you can see the fracture very clearly on the CAT scan. You see it on the left where the fracture is. On the MRI, you can't really, it's not very clear. So the CAT scan, since it's a bony fracture, the CAT scan is really the best way to view it because the CAT scan shows bony and cortex the best. MRI is not so good. But the benefit of the MRI is that you can see the disc, you can see the spinal canal, you can see the nerves. So that's the issue with spondylolisthesis. And the biggest problem we have as kids is we have like a young girl who probably has a pars fracture. You don't want to irradiate the young girl because she only has 500 ovarian eggs if she chooses to have children in the future, which most women do. So that's the problem. And the mother wants to know the diagnosis, and yet you have to say, look, if you irradiate the child, it's not good for the child. We're not going to do anything with that diagnosis anyway. We usually just say just decrease your sports playing, etc. So those are the discussions we usually have with parents all the time.
And you're talking about spondylolysis.
Spondylolysis, yeah. Or the fracture of the pars. So you may say, what's an isthmus? Well, an isthmus is a narrow body of land between two other larger bodies of land. And you can imagine the isthmus is the area between the two joints, but some medical person in the 1800s who probably liked geography named it isthmus. And that's the isthmus of Koh Phi Phi, which is in Thailand, which my wife and I went on our honeymoon. And that whole area got flooded during the tsunami. Like many people died because people hang out at the isthmus and go swimming, etc.
Is that near Phuket?
Yeah, pretty close. So listhesis just means sliding. And now the problem is you may say, well, so what if the spine's sliding? Who cares? Well, I give the analogy of the spine of many pieces of bones, like pieces of pipe, and in between the pipe there's wires or the nerve roots. And you can imagine if these segmented pieces of pipe or vertebral bodies slid, what's in the middle of it, the wire, is compressed. So it's a serious problem, and this area of the body is very richly innervated. So when it's inflamed from the sliding, etc., it's extreme. Good morning. It's extremely painful. So you can see in our spine, the nerve roots, the thecal sac, spinal cord, etc., are in between all of these segmented areas. So if the vertebral bodies slide abnormally and the areas get inflamed, it's very painful. The other thing is it's very painful is sliding joints. This is an example of a Charcot ankle that I saw when I used to take emergency room call, and you can see how deformed and destroyed it is. And when bones slide back and forth, it's a destructive process to the joints. And then when the joints gets destroyed, it's very painful. So this happens in spondylolisthesis. So when spondylolisthesis, there's all sorts of different types of spondylolisthesis. There's many reasons why the bones slide. And just so that we can explain them and describe them, Leon Wiltse came up with a classification of different types. So dysplastic is usually ones in children that develop when the child's developmentally immature. Isthmic is the area between the two facets. Now, isthmic pars fractures can occur with children too. So degenerative is usually, I think, a better way to describe degenerative spondylolisthesis is between the facets. So when the facets don't work and basically the spine slides through the facets, I think that's a better way to describe it. Traumatic is just usually you get a pars fracture from like a motor vehicle car accident. It's a big one. Pathologic, if a tumor destroys the pars area, which is very rare. And the iatrogenic is common, actually. It's when we fracture the pars, usually by the decompression, Aaron, when we do the decompression and I feel the pars and I was like, okay, don't let me go past this point, because if I go past this point, the pars will be very thin and I'm afraid he'll get a fracture. He or she will get a fracture. That's why I always say that to you during the surgery. So it's a common, I think it just happens when you're not careful, when you just don't think about it. And this goes on to who Leon Wiltse was. He was a great orthopedic surgeon on the West Coast. We won't go over that. And you can see here as an example of where the pars is. This is an L5 pars fracture. It's the place between two facets, and it basically separates the front of the spine to the back of the spine. There's another classification, Marchetti-Bartolozzi, which is basically it breaks down spondylolisthesis in the dysplastic types, which are more like children problems, versus the adult types. And I think the basic difference is when it occurs and when it occurs in the body. When it happens in children, it can cause severe deformity. So you can see here a very large slip at L5S1. The sacrum is rounded, and also the L5 pars is elongated. So what happens is how does the pars elongate? It breaks and then it heals. It breaks and then it heals. It breaks and heals. Breaks, heals. Breaks, heals. Breaks, heals. And then during this healing process, the thing gets elongated. So that's how children can get these deformities. This deformity doesn't happen in adults. I mean, it comes from childhood. And you can see here on the left a case of spondyloptosis where in a child it just keeps deforming, keeps deforming, keeps deforming. And the sacrum is round, the top of the sacrum is round. And if the sacrum is round, usually because if you have increased pressure on a growing physis or growth plate, the bone decreases the growth. And you can see this in Blount's disease on the right there. The proximal tibia is round, and it should be straight across. So when you have these abnormal forces across a growing growth plate, you get these shapes, these abnormal shapes in bones. So that's what happens. That's how children get these severe deformities at L5S1.
How old is the child on the left?
I mean, that on the left, that's an adult. But that deformity, by the shape of it, occurred in childhood.
Yeah.
So an adult will not develop that, or mature. Now, some people develop the spondylolisthesis because the facets don't work, or they're not present. And at L5S1, we call it sacral hook deficiency. But the same thing can happen at 4-5. The facets just don't work for some reason, and then the bones slide through the facets. And there's no pars fracture. It's just a facet problem. So these are some more facts for you guys. 5% of all human beings develop this by the age of 6. So it's very common. And the prevalence of this is 6 to 10% in adults, spondylolisthesis. We're the only animal that develops spondylolisthesis and pars fractures. So that tells you something, that it probably has something to do with the fact that we're upright. It only happens in ambulatory people. So people who have never walked in their entire lives, they never develop spondylolisthesis. Again, that's another maybe fact that it happens only with upright position. The Eskimos are more likely to get it. I won't even get into that. That comes from an anatomical study from Cleveland Clinic where they have. Do you guys know about the Cleveland Clinic the Cleveland bone repository? It's a fascinating place where there's, I think, 1,000 specimens or something, 1,000 skeletons, and they use it for research. and they're all documented, and people just go there and they research a bone or bones or skeletons. It's a great resource for people. I've always wanted to visit it, but I will one day. Maybe with one of my children, I'll go. My wife, she would that would be a hard time for her, to go look at bones. For her, you might as well just.
Especially in Cleveland.
Yeah. Yeah, for her, it would not make any sense whatsoever. But my children they would be interested. So we'll go back to our case now. So Aaron, again, 57-year-old man, low back pain, left hip pain, right lateral thigh pain. What do you see on the MRI?
Well, same thing now for spondylolisthesis.
Yeah. And
2-3
degenerative disc disease. Yeah. And you can see clearly where the spondylolisthesis is and where the disc is abnormal there. The rest of the discs look very good. Right? Yeah. And here's another view. You see the spondylolisthesis level, and the rest of the spine is very good. Similar findings, L2, L3 degenerative disc disease. More of the same. Here's a picture of the pelvis and the sacrum, and pretty normal. This is L5S1, large spinal canal. You can see in the center. L5S1 facets are totally normal. Now this is at the level of L4, and you can see the pars fracture. I'll point it out to you right there. It's the pars fracture, and you see it's elongated. So in this man, the surgical treatment, I decided he wanted surgery because he wasn't getting better, was just L405. So I thought the L405 segment had the most deformity. I chose not to treat the L203 degenerative disc disease, and that's like a long discussion. Do you guys want to get into that, or? Okay, so so L405 spondylolisthesis pars fracture. The treatment is fusion in this man. And basically you weld the two bones together. So this is the intraoperative X-ray, lateral X-ray, and you can see the little needle in the back, so I know where I am during surgery. So my incision's in a good place. I get down to the spine and then put a marker just to be clear where I am. It's the only way you can mark the patient. Like, it's not like a knee scope where you can mark the skin. In the spine, you really have to mark it with a clamp, with intraoperative, with X-ray. That's the only way you can mark it. And then we placed screws across both levels. And in this man, we used the cannulated screws because, like I said, he had very thick muscles, and those muscles get in the way. So it's very easy to do this through stab incisions and cannulated wires, because then you don't have to retract the muscles. Basically, you could just. I still open the spine because I want to see it with my eyes. I don't like doing an X-ray because I know the anatomical landmarks with my eyes. But then once I know where the screw should go, I just drill a hole, and then through a stab incision percutaneously, I stick the guide wire into the spine. So it's I use kind of like a hybrid technique. Some doctors just use the fluoro, but I think with the fluoro, there's a good chance you could spear or injure the nerve, and once you injure a nerve, there's no comeback to that. That's like a permanent problem. So that's why I prefer to do it the standard way, to be sure where I am, and then I use the fluoro for the rest of the procedure. So these are just inserting the screws with the different instruments we use. And so here we are, screws are in place, but you see the spondylolisthesis remains. And we got a front view, AP view, just to make sure the screws are well positioned, angulated immediately. And then through the instrumentation, we reduce the spondylolisthesis. So can you see that? You see the spondylolisthesis now is reduced. And the way we do that is we just lock one screw, and then through a special instrument, it basically pulls the body upwards towards the rod. And most of the systems have these sort of devices.
So which vertebra are you moving?
4.
Yeah.
So 5 is fixed,
Yeah.
and you pull 4 up. But 4 is connected to the whole body.
Doesn't that put 4 out of alignment with 3?
No.
Okay.
So the whole deformity is at 4-5. So you're pulling 4 up, which is connected to the rest of the body, backwards to be lined up. And here he is post-op standing. So the post-op standing view is important because you want to be sure that everything looks the same when he stands up, because it can always shift. It can always go back. So deformities want to go back to where they were always. So you may say, well, why do you reduce it? A couple reasons to reduce it. If you reduce it, the spine is normally aligned now, so there's a less probability of adjacent segment deterioration. So the spine's not crooked and the gravity line's normal. So if you just leave it in place, there's a higher likelihood probably of a persistent deteriorative process above, because now the spine is still crooked, sort of. It's unclear if that's true or not, but it's, in theory, that's possible. The other thing is when you line up the bones better, it brings the transverse processes, which you fuse, closer, so I think there's a higher chance it will heal. Again, it's controversial. Another reason to line it up is the spinal canal gets aligned better. So the spinal canal, remember the wires that were shifted, it will compress the nerves? If you line it up, the spinal canal is totally lined up, so the nerves have more room. Again, that's controversial because you decompress it from the backside. It may not be necessary. And also it's better for the nerve root because it opens the foramen more. If you bring it backwards, the foramen's more open and more normal. Again, controversial because it's not all the time necessary. Now, there also are risks to spondylolisthesis, to reducing it, and I'll show you. And there's also time involved. This is like difficult. It's finicky. You have to use the instrumentation. I'll show you some of the risks later on. But in this case, it was a home run. Everything was perfect. But the worst thing for results is long-term follow-up. So we'll see in long-term follow-up how he does. So almost everybody does well intra-op. It's like afterwards that people have complications. So just to go over a couple more things, anatomy is this patient had lateral thigh pain, Aaron. You can see here the dermatome distribution where L4 is. It's lateral thigh into the knee. So whenever someone says it's a lateral thigh to the knee, I always think L4. And sometimes people don't go by the rule book, but usually that's what it is. He was classic. And the other thing is when people have hip pain, you don't want to confuse it. Hip pain is in the groin and it runs down the thigh into the knee as well. So quite often it's a hip problem when people come see us and not an L4 nerve root. So they masquerade as each other. So this is one more review. Is the L4 is lateral thigh to the knee, and when it's numb, it's the medial portion of the knee. And then L5 is buttock, posterior lateral thigh, like the biceps area, lateral leg, which is the perineals, into the lateral malleolus. And numbness is in the lateral leg. The other way to remember it is the same area, when there's a nerve root and it's painful and numb, it's the same area where the muscles are that innervate. So you know the biceps femoris is L5, so if you can imagine that, and S1 actually. And S1 is more posterior, like usually more calf, more heel, lateral border of the foot for numbness. Okay, so any questions about that case?
Now, if you looked at this man preoperatively and stood him up, did he have much of a curvature?
Lumbar spine?
Yeah.
It's hard, it's hard. No, I mean, he looked normal. He looked like a normal man.
I mean, if you weigh 210 pounds and you're standing up, you're probably tipped forward a bit, aren't you? Wouldn't that put a curvature in your lumbar spine? Is that part of the etiology?
Well, it can. But if you look at this guy's those are I always get standing X-rays. Those are standing X-rays, and he was. I'll show you.
Yeah.
The MRI is laying down, but the X-rays.
How much did you focus on weight reduction in this guy?
Well, let me first answer your first question. Look at the lateral there.
Yeah.
The lateral, that's normal. That's good lordosis. So he looked normal.
Okay.
How much should I focus on weight reduction?
Yeah, wouldn't that help?
0.
Post-operatively?
Absolutely. 0. I never say it to anybody.
How about physiotherapy?
Commonly, I recommend it. Lately, the way that I deal with people is I just tell them, I don't tell them to lose weight. I just tell them maintain a normal calorie count, normal balanced diet, and exercise regularly. Those are my 3 things. I think if you exercise regularly, have a balanced diet, you're going to be good.
Mm-hmm.
And
if this guy had gone to a chiropractor, what do you think would have happened?
a chiropractor, he would have told him he's malaligned. He would have stretched him. There's a lot of hands-on to that. Mm-hmm. Cracked his back, made some noise. His spine sometimes makes noise of that. manipulated his body, maybe take some fear out, so that you can,
Take
some fear, remove some fear from the patient.
Yeah.
So, your body can move, or you can do these things, stretch, and just like a massage gives you benefit, it'll help them.
But there's no way you could manipulate that back into position. So.
Impossible.
Yeah. I only ask that because, a big percentage of the public go to chiropractors. So
No. The statement that you can put things back into alignment like spondylolisthesis with any kind of movement is preposterous. But it helps people. Just like, how is it when you have low back pain, how does a massage help? If you think anatomically.
I guess people feel better, so they think they're being cured.
There's a placebo effect to our brains that's 50%. So, from the cardiac, remember the cardiac in the 50s was in South America, they did sternotomies on people and their chest pain went away. You can do placebo surgery, works.
Yeah.
So to me, it tells me that we have this magical ability to heal ourselves in some ways. That's incredible. And some, charlatans sometimes, not everybody's a charlatan, but charlatans, they feed on that. They say, I did that, when they didn't. We do have the ability to heal ourselves. I don't know. What are your thoughts on that?
Yeah, if there's genuine pathology, if there's no pathology, then sure.
But we
can
can
be helped either way, I suppose.
This is the paradox.
Mind over matter.
It's mind over matter, but the mind can remove symptoms from a serious deformity.
Mm-hmm.
So, there is. I used to have an old orthopedic surgeon who used to always tell us the story of the headmaster Finney at Gilman played linebacker for Princeton with a grade 2 spondylolisthesis, which is exactly what this guy had, and he never had a back problem in his life. So he said, therefore, nobody needs surgery for this problem because, Mr. Finney played linebacker for Princeton. So some people are normal with these deformities and some people not. And why? Why can one person be normal, one human being function as normal, and the other one has debilitating pain? But what is your answer to it?
Why did this guy get this problem? This particular man get this particular problem?
He's a genetic predisposition to have weakness of the spine. He's just like everybody else, 1 out of 20 people. Mm-hmm. Why did it present at the age of 57? I have no idea.
Is it something to do with his job?
Possibly.
Mm-hmm.
Possibly if he was an accountant, it wouldn't hurt.
Bad posture, overweight plus bad posture plus his job.
Maybe.
Abnormal movements in abnormal positions.
Maybe. Well, he's had this for 20 years. Well, why does it hurt now?
Yeah.
I don't know.
Mm-hmm.
I have no idea. I think it's interesting.
Different people's perception of pain. Like, everyone feels it differently. And so I think that leads into a lot of it. Certain people, you see some people that, oh my gosh, they've had so many things throughout their lives or lived with things, or like farmers, that they live with pain every day. But they're like, oh, it's nothing more than, I'm still getting on the tractor, blah, blah, blah. And then it gets to a point where it tips them over the edge that, oh, now I can't move my legs, so I came in, but they dealt with pain. It's their perception, I think, is the thing.
Yeah, I don't know. It's societal. Okay, that's another discussion. So this is Top Thrill Dragster, David. It goes 427 feet high. It goes 120 miles an hour, and the whole ride's only 30 seconds.
Oh.
Does that one make you sick?
No, not at all. But this one, my back doesn't feel right when it goes.
My back hurts looking at it.
No, the whole. My neck is. I'm not sure when, but I still ride them because my children demand it, and I kind of. I'm like 50-50 now. The enjoyment versus nausea and pain, they're kind of like 50-50 now.
What's the rate of cardiac arrest on that thing?
I think very, very, very. They say if you have a cardiac, don't ride it. And I don't think so. Do you think people have cardiac arrest on it? No. I don't think so.
I have seen people throw up on them, but I haven't seen heart
Yeah.
attacks.
Okay, so this is a case of interesting case. 62-year-old woman with low back pain and bilateral low extremity pain, same symptoms, different body habitus now, 5 feet 1 inches, 145 pounds. And Aaron, can you explain anything what you see? With AP is kind of normal, lateral view. Okay, I'll give you another lateral view. So that's just a standing view. So this is why we get flexion extension views. On the right's the flexion view.
So again, 4, 5.
4-5 is obvious spondylolisthesis when she flexes forwards, doesn't she? And when she extends, it reduces. And L5S1 has decreased disc height. So the MRI, now, does the MRI show spondylolisthesis
There's a little retrolisthesis.
at L5S1, but 4-5 does not have spondylolisthesis, right? It reduces in the MRI. So why is that?
She's lying down.
She's lying down. She's everything's relaxed, and the spine slides back and forth at that level. So here's the MRI scan. On the top left is L3, L4. That's a normal spinal canal, normal facets. Everything's normal. On the right is L4, L5. You can see how deteriorated the facets are. You see how the spinal canal is stenotic, and L5S1 has some arthrosis to the facets, not bad. So just to go forwards, is she wanted both levels fused, and I went over risk benefits of that. She wanted the L5S1 segment fused because it was deteriorated, and she's a pretty healthy woman, so I thought she could tolerate it well. So she had an L4S1 fusion. She does have a remote history of cigarette smoking. I mean, a history of cigarette smoking, so I used bone morphogenic protein to make sure she fuses. So intraoperatively, Aaron, what do you think of L405? Does she have spondylolisthesis?
No, it looks good.
Looks perfect, right? So it was reduced. So that's a totally perfect view. Patient's happy. She comes back 3 weeks, and you get an X-ray to look at things. And now, what does it look like?
Slip a bit.
Slid again.
It slipped back. Yeah. So anytime you fix a deformity in either a child's hip or a forearm or a spine, the body has a natural tendency to go back to where it was. So the instrumentation has to hold it still so it doesn't happen. So if the spine welds together or fuses, then you win. It's over. Once the spine fuses, it should never deform again. Although bones do creep a little bit, but not much if there's instrumentation. So in this case, what failed? Was it the instrumentation's fault? The bone gave out. So, and I'll tell you what I mean by this. So she slid back, and then I followed her 5 months later, and it didn't move. And they just go back to where they were. They don't keep going worse and worse and worse. So what happened here? So this is the artist's, who's me, rendition. Is the colored area is where the screw used to be, and basically the spine shifted forwards again, and the L4 screw sort of backed out. But really what happened is the body shifted forwards, and the instrumentation's solid as a rock, and it just stayed still. So basically the L4 screw now doesn't have purchase. But the spine doesn't shift a lot back and forth that much, and it should still fuse.
And
So
we use BMP.
and we use BMP, which is a higher likelihood for fusion. So that's the risk of reducing it, is that you just lose fixation of your L4 screw, which is not good for your fusion rate because now the screws aren't holding things still. So in this case, 62-year-old woman, we lost fixation. She still did great though.
Do you consider bracing or anything just to?
Yeah, I don't brace it because I don't think it makes a difference, and people are really unhappy with the clamshell brace.
Right.
So I don't brace.
If there was a way of putting a plate
In the
from
front,
here to here, would that help?
you could do that, but I don't think it'll make a difference.
Just-
You could do that, but it's a big deal to go in the front of someone's belly. It's not easy.
Did you stop smoking?
Nobody stops smoking. No one ever stops
And I
smoking.
would say for the first case we used BMP too, he was a smoker.
Yeah.
Did this partly happen because the bone was soft?
Yes.
So do you give people vitamin D or calcium? Or
Most people are on it already. I mean, treatment of osteoporosis is very marginal improvement. Like at the best is like 5% increase per year, and it takes a year. So I mean, I tell everybody just take calcium and vitamin D, but it takes a long time for it to work, and then when it works, it's very minimal. So I mean, it's kind of a lost cause. It's just like eating right or exercise. It's something that takes a long time to work. Everybody should do it. So the other reason why you shouldn't reduce is that is the nerve can get irritated, and I'll show you why. This is the art, again, artist's rendition. That's a pelvis, and it's not drawn to scale. Pelvis, spine, and that's the femur, tibia, and foot. You see that? And you see the nerve starts in the spine and runs all the way down to the foot. Now you can imagine if you pull the spine backwards, you see that? You're basically pulling on the nerve because the nerve is attached to the bottom of the foot. So when you reduce these cases, the nerve does stretch some. So you may say, well, so what?
Which it would normally do in everyday activity.
When you walk around, it moves around too.
Yeah.
If you pull it back enough, it'll get really inflamed, and patients get a neuropathy. I mean, the nerve gets inflamed. It usually goes away, but if you reduce a deformity that's big enough, you also can get a foot drop of L5. If you do L5S1 spondylolisthesis, if you pull backwards on the L5 nerve enough, you can get a foot drop, which is a big problem. If someone has a foot drop, then their foot drags.
Does that resolve, or?
Sometimes yes, sometimes no. So that's a risk to reducing. Usually at 4-5 you don't get a foot drop because it's the 4 nerve root, and the 4 nerve root goes to the quadriceps. Sometimes it goes to the ankle dorsiflexion, but the quadriceps, because it's such an important muscle, this is my theory, we have a couple nerves going to it, so it's very hard to lose a quadriceps. It's usually L3. You almost never totally lose a quadriceps, it's just weak, but if it's weak, that's a problem too because you have a hard time walking. So usually a 4-5 is not that risky. 5-1 is more of a risk because you get a foot drop, and a foot drop, you can still walk, but it's a problem. You don't walk well. So that's another reason why not to reduce it. So this is her 6 months post-op, and she's totally healed. So this is my theory of why we develop spondylolysis and spondylolisthesis, because we're basically the only animal that walks on our hind legs, like you remember from Animal Farm. We're the only animal on hind legs, and that's why we're in charge. And all of that ability, stress is on basically from L4 to S1. The other
orthopedic surgeon on the left.
Yeah, that's the orthopedic. Yeah, I have a joke like that. The orthopedic surgeon, that's the internist.
You've got delicate hands, though.
Yeah, I have a joke for that, and then I'll tell you some other time. And so the other thing is that we have to always consider is gravity line. So the gravity line goes through C2, center of our head, goes through the front of T12, goes through the front of the sacrum, through our pelvis, knee, and to the midfoot. So you can imagine if you have spondylolisthesis, this gravity line's pitched forwards, and then you have a lot of abnormal stress on your body. So it's better to reduce it so the gravity line is reduced. But again, there's risks to reducing. So that's why you want the gravity line to be perfect in people. But some people live at a bent forward gravity line. But it's also hard. I have another theory of why military recruits have an upright posture. My theory is because they can stand like that for 12 hours because they're aligned. So if you have a perfect military posture, you can stay like that for 12 hours because you're balanced, and its ergonometry is perfect. Ergonomically it's perfect. So that's why military recruits stand at attention, because you maintain that forever. But if you try to stand at attention bent forward, you probably 10 minutes tops. So that's my theory.
Now everybody's using a cell phone, and they're like that.
Right, I know. Everyone's like glued to their phones. Okay, so this is the Maverick. This is at Cedar Point 2. It goes in. Actually, it's more than 90 degrees. When you go down the first hill, you're looking at the track. Kind of interesting. So, you want to do one more case? We good? Okay, this is the last one. This one makes you sick when you go on it. It's not that scary, but it's more like fun, the Maverick. Mm-hmm. So this is a 73-year-old woman with just exclusive right leg pain and sciatica. And you can see at L5S1, she has a grade 1, almost grade 2 spondylolisthesis. And when she flexes forwards and backwards, it moves some, but not a lot. So here's the MRI scan. It's slightly reduced. The L5S1 is slightly reduced in the MRI scan. And you can see the foramen's tight at L5S1. I'll point the foramen. The foraмен's right there. So it should be a circle, but it's stenotic. So in this patient, it's just a sacrum. And that's just the L5S1 segment. You can see the facets, L5 again, L5 pedicle. So in this patient, I consider her age and she had just sciatica, no back pain. So we decided just to do a decompression only. And this is my intraoperative notes of the laminotomy that I did, and I could see the L5 nerve root during the surgery. And I am 100% convinced I decompressed that L5 nerve root. I mean, I was convinced. I looked at it, I showed it to my assistant. See the L5 nerve root? Do you agree with me? The assistant's like, yeah, I see it. I think we're good. Decompressed it. Pain never got better. So it was very disconcerting. It was a small operation, but the patient came back, says, Doc, you're nice, everything went perfect, but I don't feel any different. So this is a case of where, so what I did is I took her back and I fused her and I did a revision decompression. I still waited like a month or two. I was hoping it would just get better. It didn't. So this is a case where you needed, the area needed to be fused because the motion was the problem. The fact that the level had instability, it would inflame the nerve root. So even though the nerve root was open, the abnormal motion at that segment was irritating the nerve, so she needed a fusion. Now, I didn't want to do it initially because it was a big operation for someone at the age of 73, but that's what was necessary.
And how'd she do?
After I fused her, she was great. She was totally happy. And here's an AP view of the fusion. I used to put a screw in the pelvis because I wanted another point because there's I put a pelvic screw because you can see if I just put a sacral screw, there's a high likelihood that that screw could cut out. Also, her bones were very, very weak. So, and because it was unstable, I felt I needed one more screw in the pelvis to hold things still, so she'll fuse. Okay, I think that's enough for today. These are just. Let me just one more thing. This is one last thing I want to explain is pelvic incidence. We went over gravity line, but also the shape of the pelvis. The shape of the pelvis dictates our alignment. So some people's pelvis is different than others, and some people have a pelvis that makes the sacrum more vertical. So some people they're just born like that. Like the pelvis, the hip, where the hip and the sacrum are different in some people, and because of that the gravity lines shifted, and that makes people more likely to develop spondylolisthesis because their spine is at a different angle, so it's more pitched forward, so it's because of gravity it's more likelihood to deform. So that's an independent risk factor, is the shape of our pelvis, and it's kind of like a new concept that was described in France really initially. But now we're more into it. But you can't do anything about the pelvis, really. I mean, you can't really cut it. I mean, you can in some kids when they have a hip problem. You can't do it in adults. I mean, some people. I mean, it's possible, but it's a big deal. So it's just something that we need to understand is present. But there's nothing we can really do about it.
Are there racial differences?
Actually, I don't know.
I remember when I was doing my obstetrics for a patient, we had African ladies, they had a platypeloid pelvis. We had a different configuration or shape or something.
Yeah. Yeah, no, you're right. I remember that from medical school too. Yeah. The different races have different shapes, pelvis. I'm sure there is. I mean, that's a different topic, but you're right.
Yeah.
There probably is a difference. Okay, I think that's it for time. So any questions about spondylolisthesis and whether to reduce or not? Should we reduce every case, Aaron, or which ones should we reduce?
Big, strong men who don't smoke.
Big men?
Did anybody ever design a screw that would have outriggers to get a better purchase, so that when the body slides forward, these outriggers give a better purchase? You know what I mean? Something like a movable fish hook, or the same principle as
he's like a true Harford County farmer. You know, he's making things
what a
work.
molly bolt is?
Yes, that's
Like
exactly
a
what
Molly
I
bolt. You go through the drywall.
And it spreads.
It spreads, and then you got a better purchase.
Oh, I see what
and
you're saying. That opens?
Yeah, it opens somehow. Yeah.
Not in the
No.
spine.
Yeah.
A similar contraption like you described was made for a tibial nail, the hooker. It was called I forget. It was a Hopkins. It was a Hopkins professor, and he had a nail like that that opened up instead of putting screws. No, there's no such thing in the spine.
Depends on the density of the bone too. Hard bone obviously wouldn't need it.
Yeah.
Osteoporotic bone you would, but that would vary too.
Yeah. It probably. Yeah. I mean, it may work. It's interesting. Basically, osteoporotic bone is you shouldn't reduce it. It's just it can't hold the screw. Some people have very when you do surgery on bones, it's amazing the difference in the bone strength. Don't you think, Aaron? Aren't you surprised? I mean, some people have terrifically strong bones, and then especially the elderly women. I mean, I can break the bone with a Penfield 4. I can just go through someone's cortex. And you're doing a surgery where you're imagining, it's like, how does this person not suffer fractures all the time, right? You're thinking, like, how do they live like this?
Yeah.
How can they, like, just get bumped in the grocery aisle to get a fracture? It's amazing the difference. Okay.
That was interesting.